Hello and welcome everyone. My name is Matt Shepard and I'll be moderating today's practical tips for getting and keeping Medicare covered care, presented in partnership with the Christopher and Dana Reeve Foundation's National Paralysis Resource Center. Our presenters today are Center for Medicare Advocacy Associate Director Kathy Holt, Attorney Louise Corcoran, and CMS Associate Ombudsman Barbara McCoy. We're also pleased to be joined today by Kim Beer, Senior Director of Public Policy and Advocacy for the Christopher and Dana Reeve Foundation, to tell us a little bit more about them and their mission. The Center for Medicare Advocacy, as many of you probably know, is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy. We have a little bit of housekeeping to do before we begin. Closed captioning today is available courtesy of the Christopher and Dana Reeve Foundation. The link to that live transcript is available right now in the chat for this session. You just open the tab on your control panel that says chat, and you should be able to see and click that link, and it will open in a new window. In addition, we have our ASL interpreter today, Catherine, who is on screen right now. Thank you for joining us. Finally, for the bulk of this presentation, probably for the whole presentation, we're going to keep folks muted. We may not have time for live questions, but if you do have something you'd like to ask, please just enter a quick sentence or two on what you'd like to discuss in the question section of that control panel I talked about. Then I can review on it and call on you and unmute you if we get to that. The reason I say if is because we received literally hundreds of questions and comments during the registration process, and thank you very much for those. I know our panelists are going to try to address some of the themes they found in those hundreds of questions today, so that might take up some of our time. So as noted, we're about to start our broad and hopefully a quick overview of Medicare and practical tips. But if you want more in-depth discussions of some Medicare issues, check out our recorded webinars on medicareadvocacy.org. I want to thank you all again for attending. And now I'll hand things over to Kim Beer, Senior Director of Public Policy and Advocacy for the Christopher and Dana Reeve Foundation, to introduce things. Kim.
Thank you so much, and welcome to everyone who's logging in. We're close to 500 attendees. My name is Kim Beer. I'm the Senior Director of Public Policy and Advocacy at the Christopher and Dana Reeve Foundation. I am a white woman in her late 40s with a chin-length brown hair, sitting in my office with a clear glass window behind me with a lot of lights. Again, we're thrilled to co-sponsor this really important, informative event. And the Reeve Foundation has been proud to operate the National Paralysis Resource Center for over 20 years. We hope many of you have been able to contact us for services, but just as a reminder, the Resource Center promotes the health, the well-being, and independence of people living with paralysis, spinal cord injury, or mobility impairment, as well as their caregivers and families. We provide free, comprehensive, personalized information, resources, and referral services to achieve a better quality of life. Many of the calls we receive are related to access to care, including insurance questions, especially around Medicare. So we're thrilled to have our experts here to present us with very important information, and please reach out to the foundation with any additional questions. I'm going to pass it over to my colleague now at CMA, our wonderful partner, and we hope you enjoy this webinar. Thank you so much.
Hello,
Thank
Kathy.
you so much, Kim. Welcome, everybody. We'd like to start with our agenda today. I'm Kathy Holt, and I'm Associate Director, as Matt mentioned, at the Center for Medicare Advocacy. I'm a white woman with glasses and shoulder-length light brown hair, wearing a white top and a salmon-colored jacket. I'm in my office. There's some plants behind me. So again, I'm really happy to be with you today. We're going to march through this program almost as if it's Medicare speed dating, meaning we're not going to stop on anything for very long. We just want to make sure that you have a sense of what Medicare is about. And we had gone through as Matt mentioned, all of the questions that you sent in pre-registration and built this program around those questions. So we will be providing a brief overview of Medicare for those of you who are very interested in how do you choose the Medicare options that you have for you. We'll be looking at how do you pay for Medicare. And some of those programs are going to be if you have very high income, and some of them are going to be if you have very low income. So why is there a difference and what can you do about it? We're going to look at coordinating other insurance with Medicare because we know there are a number of people who have more than one plan in addition to Medicare. We're going to spend the most of our time talking about understanding and using Medicare covered services. Having the ability to understand what you're covered for is half of the work of advocacy. Once you know what the coverage is and you feel comfortable with that, you feel confident with that, then you're going to be able to make sure that you can get those services, at least that you can advocate to get those services. And Louise will talk about appealing denials of Medicare covered services and finding helpful resources. And then we'll turn the program over to Barbara, who will talk about the work of the Medicare Ombudsman's Office and how the Medicare Ombudsman can be helpful to you in your questions and responses. Then we will, as Matt mentioned, go to questions, comments, and discussion, more specifically about the feedback that we got from you in the pre-registration and that we were not able to cover generally through the program. So that's our agenda. Okay, so again, practical tips for joining Medicare. A brief overview of Medicare has 4 parts. So we have Part A, the hospital insurance, and Part B, medical insurance. That's known as original Medicare or traditional Medicare. In addition, people have supplemental policies to pay for the cost sharing that Medicare doesn't typically cover. So for those, we have Medigap plans, Medicare Savings Program, and retirement plans that may act as supplements to Medicare. In addition to the traditional Medicare or the public Medicare program, Medicare Part C is known as Medicare Advantage. These are private insurance companies, and the Medicare Advantage programs can either have a prescription drug component or be standalone for those individuals who may have other prescription drug coverage, say through a retiree benefit. And then again, the last part of Medicare is Medicare Part D, the prescription drug program, those standalone prescription drug plans. A few more words about Medicare Advantage, or also known as Medicare Part C, those private Medicare insurance plans, just as a descriptive so you can understand the distinction between public Medicare and private Medicare. Medicare Advantage plans are just another way to get your Medicare benefits. They're not on top of traditional Medicare, they're an alternative. Medicare Advantage plans contract with CMS, the Centers for Medicare and Medicaid Services that administer the Medicare program. Medicare Advantage plans combine traditional Medicare and often the prescription drug component. They have essentially the same coverage rules as traditional Medicare. Everything that's offered in traditional Medicare Parts A and B are required to be covered by Medicare Advantage plans, and they also may offer additional services. Medicare Advantage plans, again, are not supplemental insurance. They are an alternative to the public Medicare. And generally, none of those supplement plans that I mentioned, those Medigap plans, are allowed with Medicare Advantage plans. So here's a brief slide on the differences between traditional Medicare and those private Medicare Advantage plans. If you're in traditional Medicare, you can see any participating or enrolled provider across the country in any of the territories. If you're in a private plan, you are limited to the networks, the providers that are contracted with the private Medicare Advantage plan. Traditional Medicare, you have to pay your premiums for Medicare Part A if you are required to. We're going to get to that in a second. and Part B. If you're in a private Medicare Advantage plan, you still have to pay those same premiums, and you may possibly also have to pay an additional Part C or Medicare Advantage premium. Reasonable and necessary care is determined by the treating providers in traditional Medicare. It's a direct line between the patient's providers and the public Medicare program. There's limited prior authorization. There may be some prior authorization in traditional Medicare for instance, durable medical equipment for customized high value type of equipment. However, in private Medicare Advantage plans, there is frequent use of prior authorization. Utilization management, meaning there's another layer of decision makers within the Medicare Advantage plan that will determine if your claim for Medicare is reasonable and necessary in addition to your own treating doctor. And there are cost management restrictions with regard to private Medicare Advantage plans. In traditional Medicare, there's limited medication, dental, vision, hearing coverage. But remember, you can get a private Medicare Part D plan that will cover your prescription drugs, and you can put together your own kind of customized plan. With private Medicare Advantage, you want to pick a plan that covers your medications, and they may also offer some limited value additional coverage. I say limited value because you want to check how much services, how many, like is the dental coverage one cleaning a year that you have to go to 3 in-network providers, or is it more expansive? Is it more comprehensive? So you want to look at what the value of those extra services that you may get in a private Medicare Advantage plan. In traditional Medicare, there are relatively seamless patient claim experiences with Medicare in a supplement plan. You go to the doctor, Medicare pays for that. Medicare tells the supplement plan to pay the copay, for instance, or the coinsurance of 20%, and the patient claim experience is rather seamless. Whereas in private Medicare Advantage plan, there's significant patient involvement with claim experience for out-of-pocket costs. So how do you choose? How do you personally choose? This is really our first big tip, is to get a personalized, customized assessment of your situation by contacting the State Health Insurance Assistance Program in your state or in your territory. And you can find those at that assistance program here at this website. They will provide, again, individualized assessment, and it's unbiased, meaning there's no compensation. These individuals are highly trained in Medicare, and they can provide that information to you for free. So again, enrolling in Medicare, you're enrolling for the first time. Practical tips. Know when you need to sign up for Medicare to avoid possible lifetime penalties. There are very specific times to sign up for Medicare. We have, as Matt mentioned, we have a lot of recorded webinars on enrollment specifically. So if you want to learn about that, we have, again, as in most of the things that I'm going to talk about, we have more specificity. Consider why you need to have medical insurance and coverage for potential catastrophic illnesses or conditions. And this goes back to the comment about Medicare Advantage plans and knowing the value of those extras. Why do you have medical insurance? And for instance, if you choose a Medicare Advantage plan because you really want the dental that's not covered in traditional Medicare, think about getting an additional dental plan that may, for your circumstances, be the way to go. One of the things that often prevents people from having those choices, if you will, is the cost of those programs. So everybody has to kind of look at their own specific situation and their needs. But do think about being on Medicare for decades. If you're under the age of 65, you could be on for decades. If you turn 65 and you live to 105, you could have 40 years of Medicare. So you want to think about the implications of the decisions that you make today as well as in the future. and determine what choices you make will help you to sleep best at night. And some of that is certainly financial, some of that is health related, and again, with all the different options that you have, think about the implications of where you live. Every state has, for instance, different rules around Medigap plans. So knowing what your options are will really help you to achieve that. So now we're going to look at the questions that we had about paying for Medicare. Most enrollees have premium-free Part A. It's somewhere between 95 and 98% of people have paid into the Social Security system by working for at least 10 years in their lifetime, and therefore they are entitled to premium-free Medicare Part A. Remember, Part A is essentially the inpatient side of Medicare. For those who don't have that level of coverage and they have to pay for Medicare, you can pay into Medicare if you're a U.S. citizen or if you're a permanent legal resident for at least the past 5 years. And you can just see here, I've laid out the premiums for individuals who are those voluntary enrollees. They don't get premium-free Medicare. The standard monthly Part B premium for Medicare for people who have incomes less than $103,000 this year is $174.70. That's the standard monthly premium. If you have higher incomes, so higher than $103,000, then you will pay higher premiums, and that premium increase above the standard is known as the Income-Related Monthly Adjustment Amount, or IRMA. So where does the IRMA come from? This is basically the adjusted gross income from the IRS tax return of 2 years ago, and that IRMA is payable directly to the Centers for Medicare and Medicaid Services, but is deducted from Social Security if you're receiving that. My big tip here is, even if you don't think that the calculation is correct, or even if what happened 2 years ago, maybe you've retired in the past 2 years, or you've stopped working and paying into the system for whatever reason, which I'll talk about in a second. But the big tip is pay now, argue later about the, I should say, appeal rather than argue. But you don't want to lose your Medicare. It's really sometimes difficult to get that Medicare reinstated, as we've found. If the Medicare beneficiary believes that the information that's used by Social Security in that income-related monthly adjustment amount is incorrect, you can appeal. The other thing that we do quite often is to complete a one-page form, and you can see the link here to the form, when you experience a major life-changing event. So maybe you were working 2 years ago and now you don't have that income. That's considered a major life-changing event. You might have had a divorce, you might have had an inheritance, you might have had something that changed your life and your income in such a way that you want to alert Social Security to that proactively so that you can eliminate paying that extra adjusted amount of premium. And then we have folks on the other end of the spectrum, people who have lower income. And the Medicare savings programs are available to help lower income people to pay for all or some of the Medicare costs. So those premiums, deductibles, co-insurance, co-payments, that can be paid through these programs. And I will say at least 50% of people who qualify for the Medicare savings program are not enrolled in those programs. So they're well under enrolled, mostly because people don't know they exist. Eligibility is based on income and in most states, assets or resources. And the income and asset criteria does vary by state, but here's a tip about this. Our best resource that we have found is through the National Council on Aging. There is, every year they update this great chart, excuse me, by state and territory that describes the criteria in every state. And if you want to have a free screening to see if you qualify for this program, again, you can contact the great state health insurance organizations, and they are located in every state and territory. And they will do an assessment for you, a brief screening to see if you qualify. In addition, there's the Medicare Plan Finder tool that's used to compare premiums and find further information about Medicare Part D, those prescription drug plans, the Medigap plans, and Medicare Advantage plans. And here's the link to the Plan Finder tool on medicare.gov. So in summary, practical tips for paying for Medicare. You should pay the premiums. If you have a dispute, then have the dispute go forward, but don't just stop paying. To minimize premiums for high income, complete that life-changing event form, appeal if you disagree, pay the IRMA when it's billed, and again, if you disagree, you can go back later. To determine the cost assistance with low income, get that brief screening from those state health insurance programs, and then use the Plan Finder tool to see what your options are for coverage. Now we're going to look at, excuse me, coordinating other insurance with Medicare. So if you have other insurance, the best advice we can give you is to put all that type of coverage, could be you're retired military and you have TRICARE for life, or you have a retirement benefit plan. If you have any other kind of insurance, confirm the information with what's known as the Medicare Benefits Coordination and Recovery Center. This is also known as the Coordination of Benefits Contractor at Medicare. And here's the telephone number, but you should contact all of your providers, whoever you're seeing, make sure they know what your coverage is, and that Benefits Coordination and Recovery Center, especially if you have any changes. So generally, who pays first? This was another great question that we got from a lot of individuals. If Medicare is in the primary payer position, do not wait to sign up for Medicare when you become eligible. And we can talk a lot more about that. Again, we have a lot of information about enrollment in our other webinars. But if you are duly eligible for Medicare and Medicaid, Medicaid will always be the payer of last resort. And then if you have group health plan coverage, you can see it gets a little complicated because there are different rules if you're 65 or under 65 or over 65. There are different rules if you have group health plan coverage for a larger company versus a smaller employer. So again, more kind of resources on that behalf. But double check when you're turning 65, or if you're under 65 and have a disability, double check when your Medicare should start, and then make that call to Social Security to confirm if you think you want to delay signing up for Medicare because you have group health plan coverage. So here's some just practical tips. If you're eligible for Medicare because of age or disability, you can only delay enrolling if you have other health insurance based on active current insurance. So don't be fooled if you're offered a continuation of insurance through your employer. That's not based on active current insurance. It may, if you're Medicare eligible, you have to sign up for Medicare. Don't take COBRA unless you're not Medicare eligible. So that's not a blanket statement of never taking COBRA. If there is other insurance, again, confirm it with the BCRC, the Benefits Coordination and Recovery Center. And again, confirm all insurances with providers. It just helps to smooth the process forward so that your providers are not billing the wrong people first. Now here we're going to talk about the different settings for Medicare. So hospital coverage. Medicare Part A, again, covers inpatient hospital. The beneficiary can be in a hospital bed receiving all of the services that someone who is admitted to the hospital, but that patient could be on observation status, not an inpatient. And so who might that be? You may go to the hospital because you have pain in your chest. Until they know by doing tests, is that pain indigestion or are you having a heart attack? You may be in observation status. So that is just observing until you get more results from testing. The Medicare manuals say that observation should not exceed 24 to 48 hours, but now increasingly Medicare beneficiaries' entire stay is classified as observation. And we've seen people with broken necks that have been kept in observation status for weeks. So it's not, I wouldn't say it's the norm, but it can happen and it's not unusual. There is now a required notice that the hospital has to provide oral and written notification if you are in observation status within 36 hours of arrival. And the consequences for people who are in observation status can include no Part A coverage for inpatient hospital stay, and if you're in traditional Medicare, no 3-day prior inpatient hospital stay, which is a qualification requirement if you are going to skilled nursing, for instance, for rehabilitation after your hospitalization. So again, practical tips for if you are on observation status, confirm the hospital classification. Are you inpatient or outpatient? If you're observation, advocate with the physician to change your status to inpatient. Unfortunately, you can't change it retroactively. You can only change it going forward. If you're an inpatient, then ensure that discharge planning is complete for safe planned discharge. Louise will talk about appeals of hospital denials, people that want to continue to stay in the hospital for safety purposes or more hospitalization needs. But what's, again, important to know, we've been working on this at the Center for Medicare Advocacy for a long time with a lot of collaboration with many organizations. And having taken this issue of observation status to court, we can tell you that CMS is working on an appeal right for individuals who were classified as inpatient when they arrived at the hospital, but then their classification was changed to observation status. It's not as much as we would have wanted to happen for an advocacy standpoint, but it's where we're at with what's happening with observation status. So we're continuing to work on this issue. Lots more to come on that. So the next setting after the hospital is inpatient rehabilitation facility. How do you know if you qualify for these services? You have to have coordinated multidisciplinary services, physical therapy, occupational therapy, speech language pathology, or orthotics. One of those services has to be physical therapy or occupational therapy. You have to meet with a physician at least 3 days a week, and you have to generally be have the ability to participate in at least 15 hours of intensive rehab services within a 7-day period. You have to actively participate in and benefit from the therapy. You have to make practical improvement, or you need the services to adapt to your impairments. And there's no need to achieve independence or return to prior level of function. It's just totally a matter of, can you handle the 15 hours of intensive rehab, and will it help you to either improve or adapt to your impairments? So again, this is another setting where we want to really emphasize the fact that knowing the coverage is really important in order to advocate for you to get these services. Now moving on to skilled nursing facility criteria. So you have a doctor's order and you require daily skilled care. So daily is defined by Medicare as either 7 days a week of skilled nursing and or therapy, or 5 days a week of therapy. A lot of therapists don't work on weekends. Skilled is a task that can be safely and effectively performed only by professional or technical personnel. I can't emphasize enough in every setting of Medicare that the term skilled drives the services? Do you need skilled services? And essentially, a nurse, physical therapist, occupational therapist, speech language pathologist, they are trained. Do you need that trained individual in order to have safe and effective services? And when you're talking about documentation that goes along with all of these services, using the terms, it's only safe if this skilled person does it. It's only effective for me if this skilled person does this. Remember, there's no rule of thumb in Medicare. So what's important to know is individualized assessments. Your condition, your needs are what drives whether or not something is considered medically reasonable and necessary. And generally, you do have to be admitted to a skilled nursing facility within 30 days of a 3-day inpatient hospital stay. That 30 days does allow, you may have to go home after you've had surgery in order to recover. You may not be ready to go to rehab yet. So Medicare allows you to have those 30 days. Next setting is the home health care. So you need to be under the care of a physician or an allowed practitioner, meaning a nurse practitioner, advanced practice nurse, who orders your care and reviews your needs every 60 days. And you have to have an initial face-to-face visit. You have to be homebound. That does not mean bed-bound. It doesn't even mean homebound. It means you need assistance to leave the home, either with another person or an assistive device, and it's a taxing effort for you to leave the home. You need to have at least one skilled service, as we defined on the last slide. And you could have a nurse, physical therapist, speech language pathologist. And once you're receiving skilled services, you can receive aid services up to 35 hours a week and medical social services. I will also add to this slide that that Medicare covers home health care indefinitely. There is very clear in the law that there's no duration of time limit. You can have unlimited 60-day recertifications of home health care. As long as you meet that criteria, you need a skilled service and you're considered what the definition of homebound is. Overriding all of those different services that I talked about, particularly skilled nursing facilities and home health care, is this concept that Medicare covers services, whether you're improving, you're maintaining your condition, or you're slowing decline of the condition. So Medicare coverage doesn't turn on improvement, but the need for that skilled care. So you may need skilled care in order to maintain your function or to slow the decline, the loss of function. And services can be skilled and covered when they're needed for any of those circumstances. And it can be used to provide the services or to supervise the services. So you may be getting care from a physical therapy assistant or a nursing assistant, but as long as those services are supervised by a nurse or a therapist to make sure that those services are, again, here are those words, safe and effective, then that's what the documentation must show. And there are in the Medicare policy manuals, the guidelines and the instructions reflecting these principles. And again, we have a lot of information about this on our website as well, but it's important to use these documents, these policies, the guidelines, in order to show providers who may be skeptical that Medicare covers these services to maintain or slow decline. You'll often hear the terms, and we saw this a lot in the questions that we got, I have plateaued or I've stabilized and therefore I don't get services anymore. That is absolutely not true. If you need those skilled services to maintain your plateau or your stabilization, if you didn't get those services, then you would no longer be stable. You would decline. Then those services are necessary and covered by Medicare. A few words about durable medical equipment. We got a lot of questions about DME. And I would say on this one, particularly just as practical information, make sure that your practitioner is prescribing with as much specificity as possible. even down to a model number, if there's something specifically, because if it's a vague order for services, you could get a very vague piece of equipment. And so the more specificity, the better. The practitioner needs to document the need for that in the medical record. The supplier has to give the exact brand, the form, the item, the supply requested, or work with the practitioner to find another that is both safe and effective. So again, really important. The other thing I want to mention is that services covered by Medicare include delivery, setup, and training. Nobody should just mail you a CPAP machine in the mail and expect you to calibrate it and figure out how to fit the mask and all of those things. That's not okay. And then again, just to look at the practical tips, know the Medicare coverage criteria. We've gone through those slides. You have those as resources. Knowing the coverage criteria will help you to understand when Medicare will pay. When you're talking to a provider, tell them all of your concerns so that it's accurately reflected in the documentation. And if possible, have someone with you or keep notes of your visits so you are aware what you had discussed and what you expect to be in those medical records. Know if your provider participates in Medicare and if they accept Medicare assignment. There are a number of providers, suppliers, who are enrolled in Medicare, but they don't accept Medicare assignment. What does that mean? Typically means that you will pay more for a provider who is not an assigned provider. You may also see other terms that they accept assignment, meaning they accept the Medicare allowed amount to be paid for a service or an item, such as equipment. If you're in a Medicare Advantage plan, make sure you use in-network providers or you understand the consequences of what will happen based on the plan that you have if you go outside that network. And review your Medicare summary notices, your explanation of benefits, to make sure that there's accuracy. I'll turn the program over to Louise.
And I'm going to encourage Louise to zip through her section if that's possible, because we really do want to get to Barbara by about 10 of.
Okay, thank you. Thank you, Kathy. Thank you, Matt. Good afternoon or good morning, everyone. Thank you for joining us. I will be speaking today about appealing denials, but first I just want to say I am a white woman with brown hair wearing a black top with a blue sweater, and behind me is a window and a file cabinet and my wall clock. So let's get started on appealing denials. First, it's important to start with a definition. So an appeal is an action you can take if you disagree with a coverage or payment decision by Medicare about healthcare services, supplies, items, or drugs. And it's interesting, that definition comes right out of the Medicare and You booklet that perhaps you received in the mail if you're on Medicare already, or you can find it online as well. And I have a link in the resource section where you can get that. Appeal processes do vary for each of the 4 parts of Medicare. So Kathy went over earlier A, B, C, and D, and they vary somewhat. I'll go into that a little bit more in the next slide. But follow the instructions on the written notice that you receive. That's a very important piece of advice, because each notice will tell you what needs to be done next while you're in the appeal process. There are several types of appeals. One is an expedited appeal. We sometimes hear that called a fast appeal, and that is used to keep services in place. So that is typically seen in settings such as home health, SNF, skilled nursing facility, and hospitals. A standard appeal is used to obtain payment for services that have already been received. So typically for a standard appeal, you may have received, for example, a Medicare summary notice. Sometimes people still call that explanation of benefits. And the last page will be your appeal process if you disagree with something on that explanation of benefit or MSN. Just a quick warning, because we're speaking about the appeal process, it's important to know that there is, plans typically have grievance processes as well, and sometimes they're called complaint processes, but these are used for different things. They are not used, as the definition says, if you disagree with a coverage or payment decision. They would be used more for activities or behavior that you disagree with at a provider facilities, for example. And it would be not about an individual claim that you would like to appeal. So hours of operation, a personnel issue, maybe perhaps there is an operational issue or a quality of care issue that you would like to file a complaint or a grievance. Next slide, please. Thank you. Appealing denials of Medicare covered services. Here's some practical tips. So as I mentioned earlier, read the notices to determine the contact information and the deadlines to appeal. They will vary by level, meaning you want to get to, if you want to get to the ALJ level, which is level 3, there will be varied deadlines to get there that you must file that next action, take that next action so that you can get the next level decision. So read the notices, very important, and think of the notice as your door in. So it's a doorway into the appeal process. Engage your provider, very, very important also. Your provider is an advocate on your behalf. It will strengthen your appeal. And if you perchance can also ask your provider to attend an administrative law judge hearing, which is level 3, that is wonderful also. That will strengthen your hearing and strengthen your appeal. Explain why the service or item is reasonable and necessary and safe and effective for you. So those are just some key words to make sure that you include in your appeal. And also, sounds like a small thing, but very important to notate, if you want to put it even on a couple of pages, that you are sending in a beneficiary appeal. So not a third-party appeal or not a provider appeal, but a beneficiary appeal, and it will get special attention. So as I noticed, or as I stated earlier, that notice acts as your doorway. So follow that notice to appeal through the various levels. Each one will give you the next instructions to follow. And remember, if it's an expedited appeal, for example, that will move through more quickly. And that can be done in certain situations, such as I think Kathy mentioned earlier, you are in the hospital and you are getting a notice that you will no longer be covered, and you or your advocate is hearing that you will be going home soon. You will want to initially ask for a fast expedited appeal to be able to get through those levels sooner and get a decision from the various levels before you can go to an administrative law judge. And just lastly, it's very important to keep those appeals going if you really feel that you have an argument and you want to advocate for yourself or someone is advocating on your behalf. Because at level 3, the administrative law judge level, you will speak to a real person, probably for the first time. So it's very important to try to get to that level. Okay, next slide, please. Okay, so these are just some resources. I'll go through them quickly and just point out a few things. SSA, Social Security, and Medicare, you can see the links there. Kathy went through some examples of when you would need those particular areas. We'll go to the next. This is very important. This is a great link. You can click on our slides at some point and go right to a one-page document that says, who do I contact? And for example, if someone has passed away, you can go to this document and it'll tell you exactly what to do in that situation. It's kind of a if this, then this. So we can go to the next page. Thank you. Relative to hearings again, so Office of Medicare Hearings and Appeals, OMHA, there's the link there if you'd like to just look a little bit at it, see what maybe some of the processes are, and if you are in an appeal situation, you definitely would want to look at the link that is provided there. And there are rules and procedures in the ALJ world, and you can also get those that's provided in these particular regulations that are noted here, and the same one at the end too. There is a specific section that notates all of the regulations that would govern those appeal situations. Okay, we can go on to the next. Yeah, policy manuals. So these are important also. These are guidance documents that CMS has put together. And so you just click on this link, and if you, for example, are appealing a SNF skilled nursing facility, then you would go to Chapter 8. It will be all outlined there. And then, as I mentioned, Medicare and You, a very important manual that will just give you some basic information to get started. So, for example, if you have a question on ambulance, you could look that up in the index and get right to some basic information just so that you can get started there. I think I have one more. So SHIP, Kathy went over. And so again, I'll just emphasize that very, very important group that you can utilize, and it's unbiased, free, so utilize your state SHIP organizations. So thank you, and I'll turn it over to Barbara.
Thank you so much. My name is Barbara, and I am a white woman in my mid-40s with long blonde hair, sitting in my sunroom in a blue shirt with the kitchen behind me. And today I'm going to talk about the Medicare Beneficiary Ombudsman role. Next slide. So, what is the role of an ombudsman? The Coalition of Federal Ombudsmen states an ombudsman is a neutral party who is trained to confidentially, neutrally, and independently prevent or resolve problems, complaints, or issues brought to him or her by individuals or groups, and bring about systemic change where needed. The creation of an ombudsman sends a strong message to individuals, caregivers, suppliers, manufacturers, and stakeholders that CMS provides an environment where all can be heard. Now let's talk specifically about the Medicare Beneficiary Ombudsman. The MBO position was established in 2003 with the Medicare Prescription Drug Improvement and Modernization Act, also known as MMA. This individual reports directly to the Offices of Hearings and Inquiries, and they are supported by a team of Associate Ombudsmen. And together, the MBO and the Associate Ombudsman work to facilitate customer service, improve customer experiences, and engage stakeholders. Next slide. So what does the Medicare Beneficiary Ombudsman do? This chart highlights the 4 main areas of focus for the MBO role. So we'll start in the left corner for partner initiatives. We conduct and participate in partner initiatives to obtain feedback from Medicare stakeholders and to provide outreach and education to beneficiaries. This would include events like the webinar, such as this one today, conferences and stakeholder forums with partner agencies and advocacy organizations. For inquiry review, we work with our Associate Ombudsman, our Medicare Ombudsman group, and Opal CMS components, and we'll talk about those shortly. And we also work with contractors to analyze inquiry and complaint data to identify trends and root causes of concerns. We use this data to develop solutions to problems, identify areas of further investigation, and inform CMS customer experience improvement initiatives. The MBO is required to submit an annual report to Congress, which highlights the MBO's activities and initiatives and gives us the opportunity to provide recommendations to Congress for program improvement. Finally, what we consider the most important objective in this role is representing the Medicare beneficiary. We provide direct assistance to Medicare beneficiaries, their representatives, and caregivers by receiving and responding to inquiries and complaints. And we work with our casework staff and our Medicare Ombudsman group and the regional locations to resolve complex issues. Engaging directly with the Medicare beneficiaries keeps us informed and allows us to experience the program through their eyes. All right, so as previously mentioned, we rely on other CMS components to assist in performing the MBO work and meeting our objectives. We look to our regional office for the majority of our inquiry assistance, as well as outreach and education. The Office of Program Operations and Local Engagement, or OPAL, manages these regional offices and provides support for local engagement, outreach, and partnership development, which includes working directly with the state health insurance assistance programs that the previous presenters both mentioned. Our OPAL innovation and financial management staff handle beneficiary inquiries and provider inquiries related to Medicare Parts A and B. And then our health plan operations staff assists with the management of C&D casework, as well as plan operations. The Medicare Ombudsman Group, which is housed or located in Baltimore, Maryland, provides beneficiary customer service support, including referrals from our 1-800-MEDICARE call center. The Division of Medicare Data Analysis and Project Management provides support in collecting, analyzing, and interpreting program data and information, and informing the MBO of potential impacts on program stakeholders. The MBO coordinates regularly with these components to help understand beneficiary concerns, look for trends, and provide assistance as needed. Additionally, we work closely with our policy colleagues throughout CMS to clarify policy, inform them of beneficiary or advocate feedback, and hopefully, ultimately, we hope to improve the beneficiary experience. I mentioned earlier that we identify trends or area of concerns we want to focus on. The MBO uses government contractors to assist in conducting studies to investigate trends in known systemic issues and to identify areas for program improvement or additional investigation. So listed on the slide are just a couple examples of issues that we've kind of dug into recently. Beneficiaries under the age of 65 comprised approximately 14% of the total Medicare population in 2019. And despite higher spending and worse health outcomes, the under 65 population is often understudied. We also wanted to better understand situations where beneficiaries are disenrolled for non-payment of their Part B premium. Between January 2019 and March of 2022, an average of 6,500 beneficiaries were disenrolled from Part B per month due to failure to pay that Part B premium. We found that most Part B enrollees who lost their coverage did not regain coverage within the 3-year study period. And for beneficiaries that did re-enroll, it took over a year for most beneficiaries to regain that coverage. Another area our office focuses on is what we call the underheard or underserved populations. For example, our re-entry efforts. Elderly individuals comprise the fastest growing segment of the incarcerated population in the United States. The number of prisoners aged 55 and older increased by 280% between 1999 and 2016, so that by 2030, it is anticipated that individuals aged 55 and older will constitute 30% of the carceral population. As older individuals serve out their sentences and return to the community, many will be eligible to enroll in Medicare or Medicaid. So connecting these individuals with healthcare coverage is crucial, as older incarcerated individuals often have significant physical and behavioral health conditions. Lastly, for beneficiaries who need a kidney transplant, their Medicare coverage ends 36 months after a successful kidney transplant. For those beneficiaries who have zero access to prescription drug coverage to help cover the costly post-transplant medications that must be taken for the rest of their lives, a new benefit was released called the Part B immunosuppressive drug coverage, or PBID. So for these last two areas, the incarcerated and PBID populations, we worked across federal agencies, as well as coordinated within our own agency to help spread awareness of both of these new benefits. This included work groups, editing and commenting on materials, and developing resources to help people understand. So going back, next slide, going back, and this has kind of been touched on a little bit by Kathy, so I won't spend too much time on this in the interest of time, but these are the avenues for assistance. For beneficiaries and their caregivers who have a prescription drug plan or a Medicare Advantage plan, so Part C or Part D, we encourage them to contact their plan directly if the complaint is related to the plan. And we'll go over the resources for 2, 3, and 4 on the next few slides. So next slide, our first avenue for assistance is 1-800-MEDICARE number, which provides vital information to Medicare beneficiaries, their families, and to the general public. If the call center is unable to assist the caller, we do have an escalation process called the Advanced Resolution Center through the call center. And if the ARC is unable to resolve that issue, then those inquiries can be sent to either our casework division in Baltimore or to the regional offices, depending on the type of inquiry. And then our office tracks inquiries to look for trends or common issues. And then for our more tech savvy or beneficiaries or their caregivers, they can also create an account on Medicare.gov, which allows them to see their prescriptions, their preferred pharmacies. It allows them to compare drug and health plan options in their area, allows them to request Medicare summary notices. It even shows, real-time claims data once something has been processed in original Medicare. So really great resource on Medicare.gov for folks to have access to their information as well. For our SHIPs, this has been mentioned several times, the state health insurance assistance programs are state programs to provide free insurance counseling to Medicare beneficiaries and their caregivers, providing information on benefits, coverage, appeals, complaints. They really are kind of the boots on the ground folks that really can guide you when you have questions about your Medicare coverage and what other options may be available to you. So when should you contact the Medicare Beneficiary Ombudsman? While we request that beneficiaries and our partners utilize the processes CMS has in place for casework assistance, we do encourage our partners to contact us if we think if there's a systemic issue that may be impacting a lot of people or that hard to reach population we discussed. Additionally, if you think there is a topic of interest you would like our office to research. There are 2 other ombudsman positions that report directly to the Offices of Hearings and Inquiries, the Competitive Acquisition Ombudsman and the Pharmaceutical and Technology Ombudsman. While these individuals do not typically work directly with Medicare beneficiaries, they provide support to the Medicare Beneficiary Ombudsman and to other industry stakeholders. So the Competitive Acquisition Ombudsman was established in 2008 and is responsible for receiving and responding to complaints and inquiries made by suppliers and individuals regarding the application of the Durable Medical Equipment, Prosthetics, Orthotics, and Supplies DMEPOS competitive bidding program. And Kathy kind of alluded, there were some issues and concerns, lots of questions about DMEPOS. And so we do have an ombudsman. The competitive bidding program is currently on hold, but there is still an ombudsman in place for that. And then we have our Pharmaceutical and Technology Ombudsman, which was established by Congress in 2016 and is responsible for receiving and responding to complaints, grievances, and inquiries that are from more the pharmaceutical and biotechnology, the medical device folks, regarding products that are covered or maybe they're seeking Medicare coverage for those products. So to summarize, the Medicare Beneficiary Ombudsman role was established to investigate and address Medicare beneficiary inquiries and complaints and to facilitate customer service, engage stakeholders, and improve customer experiences with the Medicare program. The MBO collaborates with a number of internal and external stakeholders in order to meet these objectives. Thank you so much for the opportunity to present to you all today.
Thank you very much, Barbara. Now we are almost right up against our limit. I know we're going to lose Catherine, but I also know that Kathy wanted to come back up here and address a couple of those major themes. So if you all are willing, we can stay on here for a few minutes and discuss some of our big picture questions.
Thanks, Matt. Yeah, I appreciate that, everybody. It was a big task to try to fit all this that we wanted to talk about in an hour, and obviously we've done the best that we could as far as that's concerned. I think there are just a few things that I would touch on with regard to a lot of the inquiries that we got, and I want to make sure 3 in particular. One is contacting Social Security. Social Security has been struggling with its customer service. Some of it's slow. So I would say, just as a couple of practical tips, Social Security operates from 7 a.m. Eastern to 7 p.m. Pacific, I believe. I think they just kind of, their hours are posted for the continental US. I would say if you call first thing in the morning, obviously it's like 4 o'clock on the West Coast if you're calling at 7 a.m. Eastern time. And the same thing if you call at 7 p.m. Pacific time, it's 10 o'clock here in the East. Try to call on either side of those time frames. You're more likely to get through, and also depends on the time of the month and the day of the week. So more frequently, they get calls on Mondays. So Mondays is a heavy day for Social Security. So just to kind of think about when you're trying to get through, if you've got something that you want to talk to somebody about directly as opposed to doing something online. The other inquiry that we got a lot of comments about was the fact that people are signing up for Medicare in their window of time, the 3 months before their birthday month, and they're not getting their cards. They're not hearing from Social Security. To that, I would say at least have the reassurance that if you need to go to the doctor when you are Medicare eligible or you have some other healthcare need, that even if you don't have your card, you are covered as long as you can confirm that you have something that says that you had made that effort. If you're not already getting Social Security, if you're getting Social Security, disability, or retirement, you're automatically enrolled in Medicare, and then you would have to decline it if you have group health insurance or some other kind of insurance based on someone's active employment. But otherwise, be assured that even if Social Security is behind in their catching up, that your coverage will be at least retroactive to that time. A number of people asked during the annual enrollment period, which goes between October 15th and December 7th, can you only sign up for Medicare Advantage? No, I'm not sure where that's coming from, but maybe coming from some clarity that needs to happen with the Plan Finder tool. But just know that during open enrollment, you can sign up for traditional Medicare. Whether or not you can get a Medigap plan, I think is another issue. That will depend on each state. Your guaranteed issue for a Medigap plan for the first 6 months of eligibility for Medicare. After that, it depends on the state. You may have a pre-existing condition requirement, or it may be prohibitively expensive. And then the last thing I wanted to mention, because we had a lot of questions and comments about home health care, we're going to do a deep dive into home health care next month. We're having a webinar on June 26th. So please join us then. Louise, did you have something else that you wanted to add?
Yes, thank you, Kathy. Yes, I also in looking at the questions and that came in, I found about 3 that kind of sort of clustered into some categories here. So one is early discharges. Several people mentioned that they may be in a SNF, for example, or a hospital, and they are feeling that there will be a discharge sooner than they feel comfortable with going home. So let me just talk just briefly for a moment, and let's use that notice, our doorway, as kind of a mid-marker. So before the notice comes in, if a beneficiary feels that there is some noise going around of a discharge that may not be, they may not feel quite ready for yet, they have several ways to speak to people in the facility, and it's very important to do that. Just ask. So the beneficiary or their advocate, their family, their significant other can speak to social services, discharge planning, utilization review. There are many departments. Sometimes they're rolled up in one in certain facilities, but ask what is going on in terms of discharge planning. People who work in hospitals know that discharge planning typically starts at admission. When a beneficiary is admitted, that planning begins. So ask what's going on, and ask what type of services are being lined up for you. Are there services being lined up for you? So that's very, very important. And then the notice comes in. So there's your doorway. So you will start that expedited appeal and get a as fast as possible, response from a level 1 decision, a level 2, and eventually you will be able to get to that level 3. So tap into the resources that are available, listen, watch what you're asking to sign, make sure that there are very specific discharge instructions and that you understand them, and perhaps that might help to add some clarity to an uncomfortable situation in terms of discharge. The second one is prior authorization. We had several questions on prior authorization. And I think our best advice might be to know your plan, but we know that that's very difficult. There is, lots of information in the material that is sent to you from your particular plan. But if you are in a Medicare Advantage, for example, and there are prior authorization requirements, you really have to know when they kick in and when you need to check with a provider that they have done the prior authorization procedures. They have an incentive, they want to get paid, so the prior authorization is a very, very important step, and you can advocate for yourself and just make sure that that prior auth has occurred. And again, I think we've said this several times, but we don't underestimate the power of those providers in helping you. So that's very important. And the third was there were several questions around billing, and I think some of them are a little vague, so I'm not sure exactly what the issues are, and billing is just so complex in terms of all of the various specialties, and there is specialty billing and lots of detail underneath that. But just as a general rule, I would say that an error is different than a denial. So make sure that it's not an error, which would just be a rejection. So you can talk to the billing office and see if it's something that can just be rebilled. There might be a field on the claim that they submitted that is wrong, and Medicare has seen it as a denial, but it may not be. So for example, and there are codes at the bottom of that Medicare summary notice that you can pay attention to. And that Medicare summary notice will tell you, the code may say, for example, your procedure should have been done as an outpatient. And so perhaps it's just an error on the claim. There's a field for the type of bill, and maybe they put it an inpatient type of bill. So figure out first before billing problems become something that you feel should be appealed, if it is just an error and can just get that rejection corrected. And then if not, then the back page, I think a couple of us mentioned earlier, the back page of that MSN, or EOB as we used to call it, will give you the appeal rights if you disagree. And some of you may know, right on the face of your MSN, you'll see a big, bold no. So if you see, are all services covered? No. Take an extra good look at that and go to that last page if you feel that is something appealable. Hey, thank you. I'm not sure if we have more, Kathy, or
Thanks, Louise. I think that's going to cover us for today.
I would like to add one thing. Several people have asked in the chat about a recording of this presentation. Yes, indeed, we are recording, and I'll be sending out a link to everybody who registered once that recording is processed. I'll also make sure to get the slides out again, because apparently some people did not get those at the address that they used to register.
Great, thank you. And thank you to the Christopher and Dana Reeve Foundation for supporting this program today.
Absolutely. Couldn't say it better myself. Thank you all for attending. Thank you for staying on a little bit over to go over some of those big picture questions. Thanks to our great presenters for keeping us on time. You rock. And thanks once again to the Christopher and Dana Reeve Foundation's National Paralysis Resource Center for their support. Please stay tuned to our website, MedicareAdvocacy.org, to check on upcoming presentations and to view archived webinars. Thank you all again, and I'll now conclude this presentation.